Hey, healthcare friends, do you dread doing your notes every day? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed AI is a medical scribe on a mission to free clinicians everywhere. Freed AI listens, transcribes, and writes medical documentation for you, written in your style and ready the moment the visit is over. All you have to do is give it to your patient. Just imagine leaving the office at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence cannot replace you, but it can do the administrative work that no human should be subjected to. Get back to doing what you love, helping your patients, and let Freed AI do the rest. Welcome back to the Real Life Pharmacology Podcast. Today I've got a good list of drugs for you. I've got 5 medications I want to cover. Numbers 66 through 70. We've got Pantoprazole, Dicyclomine, Sumatriptan, Chlorhexidine, and Metoprolol. So definitely some commonly used medications here. And again, want to cover some of the most important things you're going to see in practice, as well as some of the most important things that are going to show up on board exams and pharmacology exams. So meant to help you guys study and prepare a little bit for those top 200 drugs. All right, let's get into Pantoprazole. Brand name of this medication is Protonix. This is a proton pump inhibitor, often referred to as a PPI. And mechanistically, this medication inhibits hydrogen potassium ATPase in parietal cells, which ultimately prevents gastric acid secretion and going to help with reducing acid in the stomach, help for conditions like heartburn, peptic ulcer disease, and things like that. So, dosing, that's something that comes up in practice. When should you give this medication? The ideal time to give it is 30 to 60 minutes before a meal. That's for the maximal effect. I have had situations where patients can't remember to do it, or, they take it right with breakfast because they eat breakfast right away in the morning, right when they get up. Again, ideal to do it beforehand to get that maximal effectiveness, but you likely still will get some benefit from it even if you take it with food. So take that with a little bit of grain of salt when we're talking about that administration. So if we can give it before, if we can't, it's probably somewhat effective still, but not to that peak effect. It does take a little while to get to kind of the max effect in reducing symptoms of heartburn, for example. So that's a good patient education point. Most patients will probably have tried, an over-the-counter Tums, calcium carbonate, something like that, and they tend to get pretty quick relief from that. The PPI, it might take a few days before you actually get that full effect. Adverse effect profile, usually in the short term, it's pretty well tolerated, but there are some potential associations and maybe longer term risks that you definitely need to be aware of. So osteoporosis is one, so brittle bones, pay attention to that in long-term use. Vitamin B12 and magnesium deficiency. This is definitely something that I've seen come up in practice. So again, longer-term use, and goes back to the patient education point where we want to try to limit the use of these, to kind of probably to that 8-week time frame. That's really when we want to make sure that we're reassessing patients and say, hey, do they really need this long term? Because we have some of those effects that are more likely to occur, like osteoporosis, like B12, magnesium deficiency. They're more likely to occur the longer we use this medication. Also been some associations with C. diff infections as well. Remember, that's a infectious disease that causes significant diarrhea. Last, I wanted to mention with Pantoprazole, it does avoid CYP2C19, so omeprazole does cause interactions with that. Pantoprazole, definitely to a lesser extent, isn't going to affect CYP2C19. So, big one, drug interaction with citalopram. Remember, omeprazole can cause an increased risk for QTc prolongation, and then we don't have to worry about the controversial interaction as much with pantoprazole with clopidogrel as well, the antiplatelet agent. All right, moving on, let's go to dicyclomine. Brand name of this medication is Bentyl. This is a strongly anticholinergic medication that may be helpful in relieving pain and cramping associated with irritable bowel syndrome, commonly referred to as IBS. It may modestly help improve diarrhea as well. Again, this medication being anticholinergic, anticholinergic medications tend to be constipating. So if you've got a patient with IBS with predominant diarrhea, it may help slow that down a little bit. This medication definitely has some collateral damage, and how efficacious it is, can be debated a little bit. ACG, so that's the American College of Gastroenterology, generally recommends to avoid this medication in this situation. Beer's criteria, this medication does show up on there as well, again, due to the highly anticholinergic effects. And some of those anticholinergic effects are dry eyes, dry mouth, urinary retention, constipation, confusion, sedation, fall risk, all problematic adverse effects in our geriatric patient population. So we definitely have to pay attention to that for sure and try to minimize use. Probably the most common order I've seen is 20 milligrams QID as needed, so up to 4 times a day as needed for kind of the pain and spasms associated with IBS. Again, if we absolutely have to use this medication, we really want to try to minimize use if at all possible due to the highly anticholinergic risk. From a drug interaction perspective, probably the biggest thing I look out for is additive anticholinergic burden. So, you got your first generation antihistamines, your over-the-counter antihistamines. Some of the over-the-counter sleep medications have other anticholinergics in them, like doxylamine and diphenhydramine. So those are probably the situations where patients get in trouble the most, is taking some of those over-the-counter agents that have additive anticholinergic effects. Number 68 is Sumatriptan. Brand name is Imitrex. Mechanistically, this medication is a selective 5-HT1 receptor agonist, which potentially helps with vasoconstriction that may contribute to headache symptoms. So, triptans, Sumatriptan, this is a medication that's primarily used for the management of acute migraines. We do have multiple dosage forms with Sumatriptan, which can certainly be important. When we're talking about migraines, sometimes only having an oral formulation can be problematic because many patients do experience nausea and potentially even vomiting. So, you could imagine taking an oral tablet could definitely increase that risk for vomiting, and then obviously you don't get the medication if you vomit it up right away. So, Sumatriptan definitely has some other options available, injectable, for example, that can help manage those headaches and not be given orally, where we're going to not be able to get that dose and get it absorbed into the bloodstream. Adverse effects, some CNS changes can happen, dizziness, sometimes some chest pressure. So those are kind of the common adverse effects. I've definitely heard with CNS changes, patients kind of reporting a little bit of like fogginess, that type of sensation, or maybe feeling out of it. Whether that's, recovery from their headache or the medication or a combination of both, sometimes can be difficult to say depending upon the patient you're working with there. But those are definitely some potential adverse effects there. Drug interactions, I did want to mention, there is potential for serotonergic additive effects, so SSRIs, tramadol, MAOIs. Most patients I don't it's not crazy high on my radar. But if you've got a patient who's taking, higher doses of a serotonergic drug or multiple serotonergic drugs, we probably do need to pay attention to that a little bit. It is generally avoided, triptans are, and sumatriptan in patients with uncontrolled blood pressure, ischemic stroke, heart disease, prinzmetal angina. So those are some situations where we might want to look for alternative options. And fortunately, we are getting more and more acute migraine medications in that space. So definitely look at other options if we've got some of those risks there. You will see sumatriptan combined with NSAIDs in helping to relieve those headaches. Probably the most common one I see it combined with is naproxen. So that's something to keep in mind if patients need a little bit of additional relief there. Next medication, number 69, is Chlorhexidine. This is the brand name of this medication is Peridex. It is an antibiotic oral rinse, or that's what I'm going to focus on here versus the topical product. Mechanistically, it's a positively charged type of molecule which binds to the negatively charged bacterial cell wall, and that damage, that binding, can ultimately lead to kind of cell leakage of the cell's contents and ultimately death of the bacteria. Now, where is this utilized? Gingivitis is probably the most common indication that I've seen it be used. It can be used as monotherapy, or for patients with significant pain. You may see it more likely used in a patient with an immunocompromising condition as well. So again, kind of depends upon the situation there, but gingivitis is a potential indication for this medication. Administration. So it's an oral rinse. Swish. Usually patients take about 15 mils, which I believe is a capful. Swish for 30 seconds, and then basically spit the medication out after swishing it around to help, get rid of those bacteria and help improve the condition there. There is one other indication I wanted to mention specifically. It's in mucositis prevention when utilizing chemotherapy. The jury's kind of out on this. Some studies have said it might be helpful. Some studies said, hey, maybe not. But you may see it in that situation if you've got patients that have some mucositis, or we're trying to prevent mucositis because they're on chemotherapy there. So again, jury's still out on the evidence of how well it works, if it works, but it's something that you might come across in practice. And then from a drug interaction standpoint, I really don't have any major concerns with Chlorhexidine oral rinse. And number 70, we've got Metoprolol. Brand name of this medication is Lopressor, also Toprol XL. The differences between Metoprolol immediate release and extended release. Metoprolol immediate release is dosed twice a day. Toprol XL, or the extended release, we can typically get by with once a day. Other differentiating factor here is Toprol XL, or metoprolol succinate. That's the one that's been studied or has the best evidence in heart failure. So you may see that used preferentially there. Other indications other than heart failure, angina is one that comes up fairly frequently in practice. And then, of course, it is classified as a beta blocker, which can be used for hypertension as well. I will say guidelines generally don't prefer beta blockers compared to other agents like ACE inhibitors or calcium channel blockers, but it is a potential option, and more often it's used when we've got a compelling indication as well. So if you got a patient with atrial fibrillation and they have hypertension, that definitely makes a lot of sense to use a beta blocker there versus somebody with just standalone hypertension. We're definitely not going to reach for metoprolol as a first-line agent. So mechanistically, I kind of alluded to it being a beta blocker. It inhibits Beta-1 receptors causing cardiac slowing and blood pressure lowering. Recall that beta-2 inhibition can lead to closing of the airways and worsening of breathing. And so that's going to be a potential risk with beta blockers, with metoprolol. However, metoprolol is fairly selective for beta-1 receptors. Compare that to a medication like propranolol, which is non-selective. Propranolol is a lot more likely to cause issues with asthma and COPD because it blocks beta-2 receptors as well as beta-1 receptors. Now, that can be overcome with the dose. If you're on a super, super high dose of metoprolol, there's probably more and more likelihood that you're going to block beta-2 receptors to some extent there as well. Other examples of beta-1 selective agents, atenolol is another good one, and then I mentioned propranolol is one of the classic non-selective agents there. Adverse effects. So, beta blockers tend to be a little bit sedating and can cause some fatigue. Most patients seem to be able to work through this, particularly initially, and may get used to that. But definitely something to monitor closely as we start the medication, increased dose particularly. If that sedation fatigue is accompanied with too low of a pulse, you're dropping those pulses below 55, 50, you're kind of starting to get into that danger zone when you get down into the 40s. So pay attention to that for sure, especially, if it's associated with some sedation and fatigue as well. That definitely could be a problem. Dose could be too high or something along those lines. And then got to mention the asthma exacerbation risk. Again, somebody on metoprolol 25 milligrams once a day, probably not going to be a huge issue in a patient's asthma care. But if you got somebody who's on a lot of medications, or they're very sensitive, or they've got a very touchy asthma situation, may definitely tip them into the situation where their breathing is going to get worse. So again, pay attention to that. Not of crazy high concerns, on metoprolol, kind of low to moderate dose. But as those doses escalate, or a different beta blocker is potentially used, may be more of a risk there. There is the potential to mask hypoglycemia. I've definitely seen this come up on board exams. Beta blockers can blunt some of the symptoms of hypoglycemia. Sweating still should occur. It doesn't blunt that effect, or that sign of hypoglycemia, I should say. Again, non-selective beta blockers are typically, going to blunt more of those symptoms than a beta-1 selective beta blocker like metoprolol here. And then last, with the adverse effect profile, I did want to mention erectile dysfunction. So this is definitely one of the medications, one of the antihypertensive cardiovascular medications that can worsen sexual dysfunction. So important thing to think about there. And last but not least, I want to touch on drug interactions a little bit. The biggest thing I probably focus on in practice is the additive effect of dropping the pulse. So let's say we've got a non-dihydropyridine calcium channel blocker on board. That can cause some bradycardia. You take that with metoprolol. That could potentially cause some issues there. Another one that maybe flies under the radar a little bit is some of the dementia medications, specifically the acetylcholinesterase inhibitors like donepezil. They can actually lower heart rate as well and kind of have that additive effect on top of metoprolol. So definitely a good one to pay attention to there if you're preparing for some board exams, for example. And speaking of board exams, please go support the sponsor, med101.com/store. I've got tons of resources there for pharmacists, pharmacy students, BCPS, ambulatory care, NAPLEX, BCMTMS, lots of different study materials for your board exam. So go check that out, support the sponsor. Again, med101.com/store. And if you're looking for a free PDF on the top 200 drugs, go check out reallifepharmacology.com. We've got a free 31-page PDF where I basically have put in some of the most important clinical practice pearls within that PDF and the most important things you're likely to be tested on in pharmacology. So simply an email will get you access to that, totally free. All you got to do is head on over to reallifepharmacology.com and find the subscribe button and get your free PDF there. So definitely go take advantage of that. If you enjoyed this podcast, found it helpful, please do me a favor, leave a rating review on iTunes or wherever you're listening, and share us with friends, colleagues, classmates, students, anyone who could benefit from some pharmacology education. I greatly appreciate that. All right, well, I'm going to sign off for today. Thank you so much for listening. If you want to track me down, Eric Christensen, PharmD, BCPS, BCGP on LinkedIn. You can also track me down at my email, mededucation101@gmail.com. Thanks so much for listening. Take care, and I hope you have a great rest of your day.